Welcome, listeners at home. We are on the CANGO platform for civic engagement for transformed futures. Under the topic, access to health services for chronically ill patients, I am with two speakers here who I'm going to give an opportunity to introduce themselves. And welcome to the show.
Thank you. Good day, listeners. I'm Dr. Jonathan M. Dlamini. I work at Lulama as a general practitioner, and I'm also attached to a public facility in Manzini.
Thank you. Good morning, listeners. I'm Dumsile Mavuso, founding director for diabetes Eswatini, and also a regional chairperson, SADC, for IDF.
Thank you very much for taking your time to be with us on the show. We are going to be speaking on the topic access to health services during the period of COVID-19, the global pandemic that has seen so many areas of reflection. Today, we'd love to reflect on health services. We want to hear, we've seen a lot of shift, especially with developed countries. They've been struggling, their health system have been struggling, and we're wondering what's the status of our own health system at home during this period.
I think COVID-19 being a new pandemic, it has affected many countries, including Eswatini. We were not ready for COVID-19. So what has happened, it has put some strain, one on the health workers and on the delivery of services. Why? Because all of a sudden we have quite a number of people that must be tested, so it needs more staff, and we have quite a number of people that must get enough medication to be at home, because we say people must stay at home. So if a person was taking a month's supply of medication, now we need to give at least for 3 to 6 months supply at home, and that depletes the stocks. And also initially, with the pandemic, people were not allowed to move, or they need to have some paperwork to move. So those that didn't have the paperwork and those that didn't have enough stock, they were affected because they had to stay at home without medication. So, but of late, I think we are getting to handle it well. But initially, yes, there was a big problem and disruption in health services.
Your take here?
Yes, to add on what Dr. Tela is saying, we have a big challenge. While at home, I'm a diabetic survivor, we need to have the testing kits with us. So we have discovered that most of the people that are living with the NCDs, they don't have the testing kits at home. If they do, they don't have even the equipments to assist, let me say, strips, the wipers, the lancets to check their diabetic at home. It's still a challenge. We will be staying at home and we'll discover somebody, the sugar levels are shooting up, and she won't be or he won't be sure what's happening to himself or herself. So we really need to encourage people to really have those kits closer to their homes. We have support groups. There are few that were able to assist with the glucometers. Majority of them, we don't have the equipment to screen ourselves while staying at home.
Doctor, we are talking under the topic chronic illnesses, access to services for people with chronic illnesses. If you can maybe unpack for the listener what you mean by chronic illness, what are these type of illnesses that we call chronic? And we've been saying that there has been dangers maybe of defaulting. I would say, what are the repercussions there, particularly for people that are already on medication, that are enrolled in medication? And have you seen any in your practice that have been defaulting?
Yes, thank you. I think chronic diseases, we speak about diseases where you have to take medication almost for the rest of your life. One, we have the non-communicable diseases, including diabetes mellitus, including high blood pressure, including people on HIV and on ARVs, asthma, and many others. Some they are even suffering from cancer, which is also a chronic disease. So what has been happening is that some few people did default, maybe due to the COVID, because like I've said that initially there was a problem. And some, because now most of them, they were staying in semi-urban areas where they were getting, they were working. So they have stopped working. So the clinics that we're using were the ones that were closer to their workplaces. They can't access to that now because they had to move to rural areas, which is a problem. Some were taking medication, maybe they were staying in South Africa, and the lockdown find them in Swaziland. There is a problem. But we always say that if there is that problem, a person must go to the nearest clinic and get the medication. What you find then is that he might not get the exact drug that he is taking, but he can get something that is a sister drug to that one the person is using, and it causes confusion on the person. And again, many people on chronic medication will be taking ARVs or diabetics. They need to do some frequent tests that must be done. Especially diabetes, it is more regular. With HIV, at least once in 6 months, we have to monitor how is the viral load, how is the kidneys functioning, and all that. And then if the people, they are locked down, and also they don't have money, because that's the problem, they can't access. It causes some defaulting to quite a number of people. And those who cannot travel to far places, it also causes that. So we do have some repercussions from that we saw from the COVID-19. Even now, we still have people who are not taking their medication well. Some, they complain about the diet, they don't have money. We need to improve what we give to the community. Some, they have not received much assistance from the state. Also, the government, I think they didn't plan enough for this pandemic or for any eventuality. So they can't assist the people that are mostly in need. So that is the problem, the economic factor, that clinically they cannot be seen at regular, they cannot do their tests as they're supposed to, and some, they miss some on medication because of that.
As a person on the ground, Ms. Mavuso, what has been your observations, the effects of, the defaulting as we're speaking about, and what are the reasons that maybe your organization is unearthing on the ground?
We have discovered that the accessibility of the medication, even at the local clinics or the nearest clinics, is still not there. The decentralization of the services, it's still slow in getting closer to the people. We cannot claim clinics are ready to give us the medication on the ground. It's only the hospitals. I remember there was a radio show when one called from Gege. We had told them, go to your nearest clinic, and he was short of the insulin. And we had to re-instruct that patient to go back to Magayan because we didn't want him to default. So he had to push and ask the police to really release him to go to the nearest hospital. We have a challenge, the decentralization. We know government is trying something, but it's slow. The COVID has made us to push a little bit faster what they wanted to do in decentralization. We haven't achieved, I think 20%. They have achieved their goal, but most of the clinics, I'm coming from the south, we have struggled even in hospitals to access the medication. So we really need our government to look into quickening, because we don't see COVID running away immediately. We really still need their help to say, let them, at least hospitals, let's access, let the medication be available for everyone. We know it might not be the same medication like those that have been taking it from South Africa, but at least something is better than not taking the medication at all.
I know that we had a challenge in the event of this global pandemic in accessing PPE, the personal protective wear. What has been the status now, not only the wear, but the equipment overall? What has been the status now on that one, but particularly on medical supply? Because one is aware that we closed all borders were closed, and imports and exports were very difficult. What is the current status of the medical supplies now, and is there any improvement in even accessing the PPE equipment?
There is a big challenge on medical supplies because basically we have to rely on neighboring countries to get them. At clinic and hospital level, there is an attempt to make sure that it is being delivered, but it is not enough. It is not enough what we have. And also the biggest challenge now is about the equipment that is used in clinics. Let me say some of the private hospitals, we have x-rays, machines and this and that, and the engineers, they stay somewhere in South Africa. So they cannot come in the country because if they come here, if they go back, the person needs to be quarantined for 14 days. So you find that most equipment now is not working because we can't have the engineers. So there is a problem. Even some of the vaccines, the flu vaccines in the past, we used to have quite a number in stock, but now we don't because the borders are closed, and even our neighboring countries, they have to first give to their own population before coming to us. So we do have a challenge as a country there, but I think people who are responsible, they are doing something so that we are okay. But yes, we have a shortage of the PPEs and shortage of drugs. It is there.
As we're coming to a close, probably what would be the lessons? I know we've touched on so many things. As we've said, this is a reflection point for us on many areas. What would be the lessons that you can draw as different stakeholders, particularly as government and as the service providers and health workers, as well as the clients, you know, the populace? What lessons can you draw from this to prepare us for many other emergencies? Because I'm sure this would be the last. There are always emergencies, either disease pandemics or this and that. What would be the lessons that you can draw from this experience?
I think what we can draw is that, one, we need a proper planning and budgeting for such activities. We have seen that pandemic, they just come. And then we need to follow the science. We must stop mixed messages when providing to people. That would help so that when we communicate something that people can understand, and then we follow that. And then also, we must always have enough in stock for chronic medication. Let's say a person who's taking medication, always, if he has a month's supply, he must go for the refill. He must not wait until the last day so that before he goes for refill. And in general, people should go for their checkups on the specified days so that even if there is a pandemic coming, you find that people have done their tests, they've got their medication well, it won't affect them much if we have a pandemic. And then again, is that education to everybody, to the communities. And then that are the lessons that we have learned, that we should stay ahead and follow the science and proper messaging and get information from appropriate sources like the World Health Organization and any other, because people, they get messages from anywhere and then it confuses. So it is important, the proper planning, and always have enough stock for the clients and for people.
To add on that, we need to really change our lifestyles as Swazis. We know medication is key, but if you don't eat healthy, you don't exercise, you are at risk. Your immune system won't be correct. So I would like to encourage our clients, our partners, to say, let's start growing our own vegetables at home. so that we cannot get a risk of going to town just to buy spinach. Let's start today. If you haven't started growing your own, you will have those challenges because you won't be able to balance up what's happening in your life. And what doctor has said, please, let's not wait until the medication is finished in your shelf. At least give yourself a week, if you can't give a month consumption, at least for you to keep healthy and to prevent all the challenges we might come across.
Thank you very much. I think we've touched on an interesting point, Doctor, when you were saying planning. That's a great emphasis, but one is wondering, the type of planning that we're envisioning, because we are talking at the first point that when planning, or rather coming into developing our regulations, one would actually underline the lack of probably consultations. I know it was an emergency and everything had to happen in a rush. And hence we left out so many voices. What can be our point on that one, probably just to emphasize in terms of our planning? What should it look like when we're saying we're doing proper planning? Who should be involved?
I think many structures, they need to be involved in our planning. One, at governmental level, when they are doing the budget, the consultation should filter from ministries to communities. And as well, when we have such a pandemic, the relevant ministries should come together. Let's not forget the private sector, government and private sector. Let's not forget the NGOs, the non-governmental organization. They have so much wealth of knowledge, and then they can contribute on what should be there in the planning. So if let's not forget the traditional structures. If we have everybody and the community involved, it will help, because some of the things, they are being more noticed in rural areas. Some, they are more noticed around peri-urban areas. So all those people who work around there, they should be involved and have a voice to say. And this should be a continuous process. Let's review it now and again, because what was happening last month is different from what is happening now. And even that information, let's gather it in the same fashion that we continuously gather information and make the proper planning and then management of the medical conditions.
Thank you very much, listener. We are coming to an end of our program this week. We will be happy for you to join us next week as we engage on another topic. Please do follow us again and send in your comments, and let's have the conversation around this topic. Thank you very much.